Good morning, everyone, and welcome to the Illinois Academy of Family Physicians Conference on Redefining Obesity Care, Comprehensive Primary Care Workshop. We're really glad that you are all here this morning. My name is Kate Valentine. I am on staff at the Academy, and I'm just going to take a couple minutes to do a couple housekeeping announcements before I turn it over to our speaker. First, I'd like to thank our support today. This activity was supported by an educational grant from Lilly. We are all attendees are in listen-only mode. All of the sessions today will be recorded and will be made available as Enduring CME. That will be posted on the Illinois Academy's YouTube education website for anyone to access. Give us about 2 weeks and those videos will be up. There will be time at the end of every presentation for question and answers. If you have a question, please enter it in the chat feature at any time. Myself or Dr. Wells will read these questions at the end of each presentation. Additionally, if presentations go a little bit longer and we don't get a chance to read your question out loud, faculty will remain on a couple minutes after their presentation to answer any of those remaining questions that are in the chat. We do have a conference handout page. This page includes the agenda, PDFs of all of our slides, and most importantly, that link to the post-test evaluation and credit claim. That link is also in the chat, and we will pop it in there throughout today's conference for you. Here is a look at our agenda for the day. We have 4 presentations here in the morning. We'll have a short lunch break for everyone to get up, stretch their legs, grab a bite to eat. And then we're back in the afternoon for 2 presentations and case studies. And then we will all be done by 4 p.m. Central Time. Here's a list of our faculty. You can also see this information on our handouts page. And our disclosure statement. The Illinois Academy of Family Physicians adheres to the conflict of interest policy of the ACCME and the AMA. All of our faculty, staff, and reviewers have disclosed information. Everything was reviewed, and we found no conflicts of interest. The Illinois Academy is accredited by the Accreditation Council for Continuing Medical Education, or ACCME, to provide education for physicians. This conference has been awarded a maximum of 7 AMA PRA Category 1 credits. Application with the AAFP has also been filed for prescribed credit, and that determination of credit is pending, although should receive it any day. So claiming credit, like I said, the post-test evaluation and credit claim link will be in the chat box throughout the conference. It's also on that handouts page. This is very important to get your feedback and also to award you CME credit. Please complete that after the conference. This link will remain open for approximately 2 weeks, after which we will close that, and CME certificates will be emailed to all participants. They will not automatically generate after you complete the evaluation. So those certificates will be emailed the week of May 19th. For those who will be watching as Enduring material later on, you will also be able to receive credit for those videos. And information on how to receive those with the credit claim link are in the description under each video. And now it is my pleasure to turn it over to Dr. Christina Wells, who is our conference program director, the moderator for today, and opening presenter and presenter throughout. So Christina Wells is the Assistant Professor of Clinical Family Medicine at the University of Illinois, Chicago, and a dedicated advocate for the underserved communities. Dr. Wells is board certified in both family medicine and lifestyle medicine and brings 14 years of experience for caring for patients at federally qualified healthcare centers. He also serves on the IAFP Board of Directors, chairs the IAFP Lifestyle Medicine Member Interest Group, is a longtime member of our CME committee, and the vice chair of the AAFP Lifestyle Medicine MIG. And I'm sure there's much, much more because she's just absolutely wonderful. So I will turn it over to you, Dr. Wells, to get us started for the day.
Good morning, everyone. I'm so excited that we are putting on this conference today and excited for all of are learning together today and this Redefining Obesity Conference. So welcome everyone. And we have a wealth of speakers today that are going to share with us some great knowledge. So I'm excited about what we're going to experience today. Let me share my screen so we can get started. Put this in presenter mode. Sorry, I'm looking for a presenter mode here that I can't seem to find.
Did you want to go all the way to the bottom of your screen to that start slides? Would that help?
To the slideshow. There we go. Okay.
Perfect.
All righty. Sorry about that. So I'm going to be talking about Obesity 101 for the primary care physician, and hopefully we'll be able to break down what happens when a patient is experiencing obesity and all of the different mechanisms that are going on with that. So our learning objectives for today are to define obesity and its associated comorbidities, to understand the pathophysiology of obesity, and to analyze the complex physiological, psychological, and environmental factors that contribute to obesity. First, let's define obesity. The Obesity Medicine Association's definition of obesity is a chronic, relapsing, multifactorial neurobehavioral disease wherein an increase in body fat promotes adipose tissue dysfunction and abnormal fat mass physical forces, resulting in adverse metabolic, biochemical, and psychosocial health consequences. We have to remember, though, that obesity is a disease. And it's a chronic disease similar to other chronic diseases like hypertension and diabetes. Its causes are multifactorial, and it's influenced by things such as genetics and epigenetics, the environment and social factors, immune factors, medical factors, endocrine factors, and neurobehavioral factors. It's chronic and relapsing in nature, and sustainable weight loss requires ongoing management. It can lead to a host of health complications that we'll discuss later. And there should be a comprehensive approach to weight management that includes lifestyle modifications. In individuals where lifestyle modifications are not sufficient, then medications and potentially surgery should also be a part of this comprehensive approach. And we must consider the impact of obesity not only on a patient's and individual's physical health, but also on their psychological and their social well-being. So let's talk about the classification of obesity. The Centers for Disease Control and Prevention classify obesity using body mass index or BMI. It's a calculation that's based on weight and height. For adults, obesity is defined as a BMI of 30 or higher. Severe obesity is defined as a BMI of 40 or higher. Of note, terms such as morbid obesity have been replaced by class 3 obesity or severe obesity. So let's talk a little bit about the BMI. We know that there's been a lot of talk as to whether or not the BMI is a good measure or not. The BMI has some strengths and also some limitations. Some of its strengths are that it's easy to calculate. You don't need any special equipment except for a scale. And it offers a standardized process for categorizing obesity. However, we must also recognize that there are some limitations to BMI. The BMI does not account for body type. It also does not account for muscle mass or bone density. For example, a person with a high muscle mass, such as a football player, may be mistaken to have obesity. And a person with small bones but a higher belly fat may be considered to have a healthy weight. Thus, the BMI should not be used in isolation at the individual level when determining health risks. The BMI it also does not account for ethnic variations in body size and fat percentage. The BMI, remember, if you may or may not know, that it was developed by a Belgian, usually using presumably white subjects of European heritage. This population may tend toward proportions of fat to muscle and bone that might differ significantly from other populations. So, based on this limited sampling technique, because it was only developed based on European people from European heritage, in 1994, the World Health Organization and the National Institutes of Health established obesity guidelines that were based on data from European and Caucasian Americans. So we have to remember that this BMI has some limitations. It doesn't account for body type, muscle mass, and bone density. It doesn't account for those ethnic variations. And some of the guidelines that are based on BMI are going to have limitations for people of certain body types and ethnic groups because of how the BMI was established. So remember that as we're using it, it's still a helpful tool, but it does have some limitations. Let's think about some facts about body fat. So, the amount of fat cells that are determined by birth and adolescence, but they remain stable during adulthood. Weight changes can decrease or increase the amount of body fat cells, but they won't increase or change the number of fat cells. And while it has been thought that adults don't produce new fat cells, research actually demonstrates that the number of fat cells is really stable over time because the loss of fat cells to cell death is equally counterbalanced by new fat cells that arise. Fat is stored in the body in the form of subcutaneous or visceral fat. That subcutaneous fat is a fat that we can see, and that visceral fat is a fat that we don't necessarily see. Well, actually, we can't see it because it's the fat that surrounds organs. The subcutaneous fat primarily acts as an energy reserve. It acts in insulation, and it's a source of hormones. Excessive accumulation, though, can contribute to the development of visceral fat. Visceral fat is located deeper in the abdomen and it surrounds and supports the organs, including things like the liver, the intestines, and the pancreas. However, so we need some visceral fat and we also need some subcutaneous fat, but excess visceral fat can interfere with organ function and increase the risk for heart disease, diabetes, and certain cancers. So let's look at a few types of body fat. So brown fat is mostly found in infants and it is stimulated by cold temperatures in order to generate heat. The amount does not change with increased caloric intake, and those who have overweight or obesity tend to carry less brown fat than lean persons. White fat is the most abundant type, and it's designed for fat storage. It typically will accumulate in the abdomen, the thighs, and the hips. And it secretes, this white fat will secrete more than 50 types of hormones, enzymes, and growth factors. And when present in excess, these hormones can be disrupted and can contribute to things such as insulin resistance, sorry, and inflammation. Then you have beige fat. And beige fat is a type of white fat that can be converted to perform similar functions as brown fat. It can generate heat in response to cold temperatures, or it can generate heat in response to exercise. So, when thinking again, remember we talked earlier about BMI, its strength and its limitations. Let's also think about what are alternative methods for measuring body fat composition. And there are many different methods, but in thinking about what we would use in the primary care office, these three are most commonly common measures to use and more simple to use as well. So these three simple clinical measurements for body composition include bioelectrical impedance, weight to hip ratios, and skin fold measurements. Devices such as the InBody 770 can measure body composition using bioelectrical impedance. And this is a non-invasive method that analyzes the electrical resistance of different tissues in the body. So what happens is a small, low-level electrical current is sent through the body, and the device measures the resistance that it encounters in various tissues, such as muscle, fat, and water. And then this resistance is then used to estimate the proportions of the different components. I like the this machine is a little bit more expensive, so that might be some of its limitations to its use. But they have one of these in the gym that I go to, and it's really nice to be able to use it and really look at its measurements over time. And so it's a good way of looking at body fat composition. Then you also have abdominal to hip circumference ratios. And this is where you're measuring the waist to hip ratio. And this is something simple that can be done within the clinical setting to help to determine body composition. Then there are also simple tools that can help to that can look at skin fold measurements, and that's also another way to measure body fat composition. So these are three simple methods that can be used in the clinical office. Just some things to consider though, that the reliability of these measures are going to vary on based on age and also on sex. So let's look at the epidemiology of obesity in the United States. And this data comes from the CDC. Between August 21 and 2023, the prevalence of obesity among adults in the US was a little over 40%. And that prevalence is greater in women versus men. The highest rates of obesity are in adults age 40 to 59, and also highest in those who have lower educational levels. Also, I know although this conference today is not focusing on um, pediatric obesity, I just thought that this was something that we really want to think about, that approximately 1 in 5 US children and adolescents have obesity. So definitely, these are things that we want to be thinking about and really having these conversations starting in childhood. So think about the racial disparities in obesity prevalence. The adult obesity prevalence was highest between 2017 and March 2020. It was highest among Blacks, then followed by Hispanics, whites, and then lowest among Asians. And later on, we're going to explore why some of these racial disparities may exist. So, what are some of the contributing factors to racial disparities in obesity prevalence? Non whites from low income groups are more likely to reside in isolated communities with high unemployment rates, maybe with lower educational levels, high crime rates, and limited social resources. These communities often also have a higher concentration of fast food restaurants that offer these high fat and highly processed foods. Also, access to supermarkets that sell more nutritious foods like whole grains, fresh fruits, and vegetables may be limited. This will result in poor dietary intake and increasing levels and risk for obesity. Research also shows that in racially integrated schools, the differences in obesity rates between various racial children are much smaller than statewide obesity disparities. So it's also important that school segregation, which still exists, especially in urban environments, may contribute to also these racial disparities in obesity prevalence. Also, thinking about differences in dietary choices. And those differences in dietary choices can be driven by structural inequities such as access to nutritious foods, the built environment, and also acculturation. Also, disparities in healthcare access may limit access to resources for prevention and early management of obesity related risk factors. So we see that here that the racial disparities in obesity prevalence are not a biological consequence, but are a consequence of structural inequities that result in communities that might make them more likely to have conditions that might increase the risk for obesity. So, what are some risk factors for obesity? So, certain health behaviors can contribute to excess weight gain and are risk factors for obesity, like lack of physical activity, certain eating patterns, lack of sleep, which I know we don't talk a lot about, but lack of sleep or poor quality sleep, and too much screen time. Also, stress. Long term stress can impact hormonal levels, such as cortisol levels, and that can impact appetite and food cravings. Also, certain health conditions like Cushing's syndrome, PCOS, and hypothyroidism can be risk factors for obesity, as well as certain medications, psychiatric medications, steroids, some hormones, hormonal birth control, and anti-seizure medications. And also some genetic conditions can also cause increased risk for obesity. Additionally, systems and environments can increase risk for obesity. Health is influenced by the conditions in which people live, they work, and they learn and play. And there are forces and policies that shape those conditions. These factors can impact individuals' ability to make healthy choices and influence their risk for developing obesity. And remember again that people of color and those of lower socioeconomic status tend to live in communities with increased exposure to toxic chemicals. And that can also increase risk for obesity because these toxic chemicals can be endocrine disruptors. So, some of these factors might be inadequate access to nutritious foods and beverages, safe spaces for physical activity, quality education, high quality healthcare. Access to healthcare is one thing, but having also high quality healthcare is important as well. Things such as safe housing and transportation and economic stability. So, all of these are important and can be risk factors for obesity. Something else to consider is to think about the impact of food manufacturing on obesity. Advancements in food processing technology during the Industrial Revolution led to the initiation of processes that were beneficial, like canning, pasteurization, and refrigerated transport of food. This time also, though, brought about mechanization in agriculture. And this is where human labor was now replaced by machines. These technological advancements, while they improve shelf life, palatability, convenience, and availability and safety of foods, this also led to an increased mass production of food and also led to the rise of ultra processed foods. And we know that intake of more ultra processed foods is a risk factor for obesity. And so food manufacturing, while it has been beneficial, has also changed the way we eat in America and has been a contributing factor to the rising rates of obesity. Also, food availability and affordability is important. As I spoke about earlier, some communities may lack access to nutritious foods, and this impacts available food options. There's been data that shows that dollar stores are more common in Black majority communities, and these are in Black majority communities at all income levels. And so these dollar stores will be more prevalent than, say, grocery stores. And they may, while they do have some healthy options, they may lack in the amount of these nutritious options. And so leading to a lack of access to nutritious foods in some communities. Also, there are more fast food options in Black neighborhoods. So we have to consider all of these barriers and risks when we're thinking about what contributes to the formation of obesity. Also, we got to think about portion sizes. Let's think about portion sizes over time. Think about back to the 1950s, where a hamburger portion size was about 3.9 ounces. And in 2006, the typical hamburger size was about 12 ounces. Well, where are we going? Our portion sizes are becoming larger and larger and larger. And also, what's marketed on TV. I was talking to someone the other day and I said, I don't think I have ever seen like a salad or vegetables marketed on television. But what's usually marketed on television, on billboards, are unhealthy, nutrient poor, calorie dense food options. And so our portion sizes and marketing also contribute to rising rates of obesity. Also, we have to think about things such as cultural influences and how they may impact how people choose food, their thoughts about health. And so, cultural influences will influence food preferences. They will influence individuals' perceptions about body image. There also will be specific cultural beliefs about health, food, and exercise. There are also certain cultural foods, and some of these cultural foods have been modified over time as individuals have been influenced by the new cultures that they have been assimilated into. And as individuals acculturate to a new culture, they may adopt these new preferences and habits. And this can also potentially lead to changes in weight. For instance, in indigenous African populations, they ate more fruits and vegetables. And as a result of slavery, that changed some of the cultural foods in Black populations, also in Hispanic populations. As a result of colonization, there certain foods like lard were introduced into those populations, and so they started to use lard more in their in their cooking and in their foods. Also, perceptions of foods can vary by culture. Some cultures view certain foods as symbols of status or wealth, and this might encourage their consumption. So when we're thinking about obesity, we have to be mindful that we're not thinking about, you know, just what people are eating, but why people are eating, what influences those, and all of the other factors that we'll continue to talk about today that influence why obesity forms. So now let's talk about the pathophysiology of obesity. So, energy homeostasis is a balance between energy intake and energy expenditure. Positive energy balance will drive weight gain. Positive energy balance, though, is driven by genetic, behavioral, environmental, and social factors. So, we got to remember all of those together. The physiological energy regulation involves complex reciprocal processes that include enteric sensory motor processes, peripheral hormonal signaling, and peripheral and central neurologic pathways. And we're going to explore those pathways today. So let's break this energy balance process down because I like to break things down so that it's very simple for us to understand. There are numerous complex processes that regulate food intake and energy expenditure, including complex interactions between the brain, the gut, and adipose tissue. So, sensory pathways in the gut activate brain regions that control appetite and feeding behavior. Energy expenditure is also moderated by many of these same pathways. So, resting metabolic rate accounts for approximately 70% of total energy expenditure and is closely related to free fat mass. So, for instance, the more muscle mass an individual has, the higher will be their resting metabolic rate. And the remainder of energy expenditure is attributable to the thermic effect of food and physical activity. There are specific hormonal and neurological pathways that mediate these domains of energy expenditure, and these pathways may be consequential in obesity. So, in peripheral regulation, what happens is gastric distension will result in the release of neurotransmitters. And this signaling accounts for the effect of distension on feeding behavior. So, no matter what the calorie content of food is, this gastric distension is an important source of negative feedback in food intake regulation. And so, distension will decrease appetite and food intake. So that's the first thing that's happening is as food is entering the stomach, it's causing this gastric distension, and that is causing this negative feedback signaling. Then gastric emptying controls food transit from the stomach to the neurohormonally active intestinal lumen. In adults, large fasting gastric volume, so that's people who may have a larger stomach, and accelerated gastric emptying are associated with obesity and subsequent weight gain. So, rapid gastric emptying has also been associated with alterations in satiety and increased hunger and greater weight loss in patients who've had bariatric endoscopic procedures. So, this gastric volume and the accelerated gastric emptying are associated with obesity and subsequent weight gain. Then, on entry of meals into the duodenum, various nutrients will trigger release of hormones, and these hormones will influence motility, they'll influence gastric emptying, and they also will regulate food intake. So, the appetite inducing hormones or the orexigenic hormones like ghrelin, and then there's satiety inducing or the anorexigenic hormones like peptide YY, glucagon like peptide or GLP-1, oxy oxytomodulin. I tried to remember how to pronounce that one, and cholecystokinin, CCK, and amylin. And so all of these are enteric hormones that are going to be influenced by food in the duodenum by various nutrients that enter the duodenum. So GLP-1 is secreted in the small intestine in response to the entry of glucose and fat. And this GLP-1 is going to promote insulin secretion and it's going to inhibit glucagon secretion. GLP-1 also is going to activate other signaling pathways that are going to decrease gastric emptying rates and have an anorexic effect. So they're going to decrease or suppress appetite through the promotion of satiety and decrease energy intake. CCK release also activates signaling pathways that promote meal termination, and they also are going to slow down gastric emptying. And gastric emptying, when it's slowed down, is going to increase satiety. think I went past one too fast. Sorry. What studies have shown is that that post-meal GLP-1 levels are blunted in individuals with obesity and will normalize after weight reduction. Although these studies they have not been able to distinguish causation from correlation. Also, drug trials consistently find that GLP-1 receptor agonism results in significant weight loss. Also, GIP, gastric inhibitory polypeptide, which is an incretin hormone, just like GLP-1, has previously been reported to have a minimal effect on weight. However, the combination of GIP and GLP-1 agonism results in significant weight loss. Potentially, this is related to GIP's unique role in increasing lipid uptake and storage in white adipose tissue and in an attenuation of the nauseating effects of GLP-1 monotherapy. GIP is also involved in glucose regulation and insulin secretion, in lipid metabolism, and bone health. And we still don't fully know what the roles of PYY and C. We know some of their roles of the PYY and CCK, but we don't really know if they directly contribute to obesity. So more research needs to really go on in those areas to understand more of the impacts of PYY and CCK. So what about ghrelin? Ghrelin is another enteric hormone, and orexigenic peptide hormones stimulate food intake and alterations in various GI functions. So in rat models, injection with ghrelin results in a significant decrease in physical activity and may mediate decreases in energy expenditure that can contribute to an energy surplus, weight gain, and obesity. So ghrelin is decreased in obesity and it's increased in weight loss. And this is important to consider because ghrelin will it will stimulate appetite. When people lose weight, their ghrelin is going to increase, and this is going to make their appetite increase. So it's important as you are counseling patients regarding their weight loss that their appetite may actually increase as they're losing weight because the ghrelin is going to increase. And so this needs to be taken into account and making a plan to address this as you're dealing with weight loss. What about leptin? So leptin is largely, but not solely, produced by adipocytes, and its production is closely correlated to white adipose mass. So the more white adipose mass that is present, the more leptin that is going to be produced. So signals to the brain that the leptin is going to signal to the brain that the body has stored enough energy. It's going to reduce appetite and it's going to promote satiety. So leptin is increased in obesity. But then you ask, well, if leptin is increased in obesity, then what's happening? So in obesity, what happens is that although leptin is increased, there is a state of leptin resistance. So leptin isn't doing its normal functions in terms of reducing appetite and promoting satiety because of that leptin resistance. Fasting and weight loss will decrease leptin levels. Also, mutations that decrease leptin synthesis, secretion, or biologic activity, or that may alter signaling through the leptin receptor in the brain can cause severe obesity. Leptin may be involved in alterations in both energy intake and energy expenditure. What about adiponectin? So adiponectin is also a adipose hormone, but it's produced exclusively by adipocytes. It has a major role in weight homeostasis and metabolic functions, including insulin sensitivity, glucose metabolism, and fatty acid oxidation. There are lower plasma concentrations or lower plasma concentrations of adiponectin are associated with obesity and visceral adipose burden. And adiponectin is increased with weight loss. So it's going to be decrease in obesity and increase in weight loss. Ongoing research into hormones such as amylin, which may enhance leptin signaling, um, are still we still don't really know a lot also about amylin and how it might be impacting how it might affect and how it might work in the body, but there is some data going on that amylin might impact leptin signaling. So I made this little chart here because I know that it can be really challenging to kind of remember all of these hormones, what their function is, and whether they're increased in obesity, and what happens in their weight loss levels. Because again, it's important to understand the many different hormonal processes that are going on when an individual experiences obesity, and then what happens as they lose weight, because that helps us to understand how things like appetite and satiety are impacted by these conditions, and it can help us to better be able to counsel patients. So this is a nice little table that summarizes what I talked about in terms of ghrelin, leptin, adiponectin, and GLP-1 that you can use and reference over time. And I'm not going to spend a lot of time talking about this because these are very complex pathways, but I just wanted to briefly talk about um, central regulation. And the CNS is going to receive peripheral signals from autonomic pathways, peripherally secreted hormones like the one we just discussed, and circulating nutrients. And multiple appetite centers in the brain are going to moderate these complex reward signaling pathways and feeding behaviors. The orexigenic, those are the appetite promoting agouti related peptide, and the anorexigenic, those are the appetite suppressing POMC pathways in the brain, respond to peripheral signals, and then they impact feeding behaviors. These pathways also then reciprocally influence those same peripheral pathways involved in appetite and eating behaviors. This really helps support that role of this gut brain axis in controlling energy intake and expenditure. So there is this reciprocal connection between the gut and brain and how it receives signals, and then also how it controls those peripheral pathways as well. There are also some obesogenic syndromes that, again, we won't talk about, but these are some rare, highly penetrant genetic variants that can result in severe childhood onset obesity. And these will present again in obesity. So if there's ever you're dealing with a child who's presenting with severe obesity in childhood, and especially if they may have, because some of these syndromes also present with concurrent developmental delay, you may want to do further investigation and or testing to determine whether or not any of these obesogenic syndromes may be present. Lastly, I just want to spend a little bit of time talking about the health consequences of obesity. And there are many. So we'll just go through this slide. And this is another good schematic that you can go through again later. But increased adiposity can lead to a myriad of diseases related to the promotion of things such as mechanical dysfunction, inflammation, vascular injury, oxidative stress, insulin resistance, hormonal dysregulation, mitochondrial dysfunction, and metabolic changes. Mechanical dysfunction can result from things such as airway narrowing, reduced lung capacity, increased stress on joints, and an increased pressure in the abdominal cavity. Increased sympathetic tone can activate and activation of the RAS system can increase risk for things such as hypertension. And this can be driven by altered adipokine levels, such as high leptin levels, low adiponectin levels, increased insulin levels, and impaired baroreflex sensitivity. Adipose tissue disruption can lead to low levels of oxygen within the adipose tissue, and this can lead to inflammation and insulin resistance. Altered hormones can also create a pro-inflammatory state that increases risk for cancer. Inflammatory cytokines can stimulate increased breakdown of stored fats, and this can release free fatty acids into the bloodstream. And when you have more free fatty acids in the bloodstream, this can lead to insulin resistance and mitochondrial dysfunction. Insulin resistance can also lead to cardiovascular disease. Inflammation, oxidative stress, and increased lipid accumulation can cause mitochondrial dysfunction, and that can also again lead to insulin resistance and other health conditions. Decreased hormone sensitive lipase activity can also result in the accumulation of fat in adipose tissue. Increased lipid load leads to increased lipoproteins, and that leads to increased deposition in the liver, and that can lead to fatty liver disease. And also, this increased lipid deposition in places such as the endothelium can lead to vascular injury. And so, as we can see, there is a complex cascade of complications that can result from increased adiposity. So, what are some key takeaway points? Key takeaway points are that obesity is a chronic disease with multiple risk factors. We have to understand these risk factors because it's important in treatment. We have to think about what contributes, and it's more than just what patients are eating, it's why they're eating this way. And it's all the complex hormonal and energy dysregulation that also may occur, and the environmental, societal, social, genetic, familial factors that might contribute to that. We have to remember that obesity is a chronic disease and that it's relapsing in nature, that obesity can have very serious health consequences, that there's a need for comprehensive treatment that is patient centered. We have to remember that. And I know we're going to talk about this later in the language that we use and reducing stigma around obesity as well. And also understanding the impact of increased adiposity on health. And so thank you for your attention.
Thank you so much, Dr. Wells. I appreciate that presentation. We will now open it up for some questions. If anybody has any, you can please enter it into the chat at this time. We did have one question asking about information on insulin levels and insulin resistance.
So with increased adiposity, you're going to have more increased insulin levels and increased insulin resistance. And so increased adiposity is also going to increase a risk for metabolic syndrome.
Great, thank you. And then this one just came in. It's more of a comment. I found that neck circumference a good proxy for upper body obesity, and that ABD hip limited due to increased waist due to multiparity.
Okay. Thank you for that comment. I think what I remember that those three alternative measures that I recommended earlier, none of them are perfect. And they also, in the studies that I looked up, what they were saying is that the reliability and the accuracy of those different measurements are going to vary based on age and sex, and probably multi-parity, like you mentioned as well. that affects the pelvic structures.